Hello, my name is Dr. Marysia. I'm an associate professor in the Department of Cardiovascular Medicine at Mayo Clinic in Rochester, Minnesota. And I'm here to just lead the discussion for the subtopic of our ongoing podcast series called The Intersection of Cardiovascular Disease and Female Reproductive Health. And today's topic is on menorrhagia management in women with cardiovascular disease. And I am here to introduce our esteemed expert, Dr. Shannon Laughlin-Tommaso, who is a professor and consultant in the Department of Obstetrics and Gynecology at Mayo Clinic. She's the Associate Dean for the Office of Education Engagement and Outreach in the Mayo Clinic College of Medicine and Science, where she's leading efforts to recruit the best and brightest talent from around the country and create an inclusive learning environment. Her clinical specialty is in minimally invasive gynecologic surgery, and she specializes in treatment options for uterine fibroids and abnormal uterine bleeding. Dr. Laughlin-Tommaso earned her MD and completed her obstetrics and gynecology residency at Loyola University Stritch School of Medicine. She earned her master's degree in public health epidemiology from the University of North Carolina, Chapel Hill, and holds a bachelor's degree in anthropology from Dartmouth College. I was really excited to invite her to speak with us today because many times when I encounter cardiovascular patients with concerns, particularly menorrhagia after being started on dual antiplatelet therapy or anticoagulation, she is one of my go-to colleagues and experts that I reach out to discuss patients about. And so I think she'll have a lot of helpful advice to offer as she does for me on a day-to-day basis. And I think I'll just start with saying, in clinic, I'll occasionally encounter a patient who's young, who has a significant cardiovascular history, whether it be atrial fibrillation requiring anticoagulation or a recent myocardial infarction requiring dual antiplatelet therapy. And one of my personal areas of expertise is treating women who have had cardiovascular disease history, but also women with young heart attacks. So for me, this topic comes up a lot. And one of my first questions for you are, what are the causes of heavy menstrual bleeding? Because not all of my patients encounter this, but I do have a notable subset of women who, when we put them on dual antiplatelet therapy or even especially anticoagulation, they struggle with menorrhagia, and we struggle with symptomatic anemia and other issues. So I'd love your input in regards to causes of heavy menstrual bleeding.
Yeah. Well, first, thanks for having me. I'm very excited to be here with you. You are also my go-to whenever I have questions about young women, especially with SCAD or cardiovascular disease. And you've taught me everything I know about SCAD, actually. So I'm happy to be here too. We've chatted about this before. Heavy menstrual bleeding is a huge topic. I mean, there's lots of different things that can cause heavy menstrual bleeding. And what we try to do is break it down first by is there a structural issue? Are there uterine fibroids or adenomyosis that can cause the uterus to physically change in ways in which heavy menstrual bleeding would be more common? Or is there a non-structural issue, say changes to the compounds within the endometrium, whether that's the clotting factors or prostaglandins, both of which we have non-hormonal treatment to treat. And those, we always start with an ultrasound. That kind of helps us differentiate between the structural and non-structural causes, gives us a much better idea of kind of what's going on. And then we also look at the pattern of bleeding to tell what are the causes. So bleeding that comes at really irregular intervals could be a sign that maybe there's a hormonal issue going on. And that's kind of the way I ask it is, are your periods predictable or not? Because most people will be a little bit irregular, but they might tell you that, well, they're totally unpredictable. They come and they're super heavy. And if they're really irregular and then heavy, one thing we worry about is anovulation. So just not ovulating every month, not getting that progesterone boost to really kind of clear out the endometrium. And that actually puts patients at risk for endometrial cancer. So that's a really important one to address. So starting with the imaging to look at, structural features, looking at the bleeding pattern. And then, of course, you mentioned anticoagulation, which is a huge risk for patients suddenly getting much heavier bleeding or even bleeding kind of in between cycles.
Talking about that, are there certain anticoagulants that are better to consider than others? Fortunately, with some of the newer agents, we have a wide variety of options. Warfarin, we can use, apixaban like Eliquis or rivaroxaban, also known as Xarelto. From your perspective, does that make any difference in terms of which one we start a patient on if they have an indication for anticoagulation, say a mechanical mitral valve, for example?
Yeah, there's really great data coming out now. Several studies, and I am terrible at pronouncing all the names, but rivaroxaban is the one that seems to be associated with the most abnormal uterine bleeding and the most need for ongoing treatment for bleeding. So that is one that if you have a young patient who needs to go on anticoagulation, that might not be my first choice in therapy. The other ones that when they're compared to warfarin or patients without anticoagulation are much lower risk of abnormal bleeding. So some new data coming out in that realm. I'd keep my eye on the literature on that, but I do think the rivaroxaban has been presented in several studies now as kind of the highest risk for abnormal uterine bleeding.
Are there any strategies with Coumadin, especially, or also known as warfarin, particularly in patients where that is their only option? And again, I was thinking about mechanical valves and so forth, but any thoughts there?
Yeah, I think in any patients with anticoagulation, we really want to get to the source of the bleeding, right? So, like if they have a structural issue, uterine fibroids is my specialty, and I love treating them. And there's a lot of different procedures we can do to shrink the fibroids or to remove the fibroids or remove the entire uterus. So, there's lots of options in that realm, and I'm happy to see patients for fibroid-related bleeding. However, most bleeding treatments also cover the bleeding from fibroids or adenomyosis. And I think there's lots of options. I'm always a little concerned about the risk of like causing, increased risk of thromboembolism or stroke or MI, even if they are already on anticoagulation. So I try to avoid estrogen or tranexamic acid, but honestly, they're really good treatment options sometimes. And sometimes we might reach out to you and say, if this patient's going to be on anticoagulation long term and is therapeutically anticoagulated, can we use tranexamic acid? So also new data coming out there, the risk of thromboembolism from that is a lot lower. But there are so many progestin-only medications which are relatively safe in patients like this that I think it's really helpful to think about those. So progestin-only options suppress bleeding by thinning out the endometrial lining. Specifically, some of them also block ovulation and keep the lining really thin from that standpoint. So that can sometimes help if patients have ovarian cysts or ovulatory pain as well. The most effective progestin-only medication is usually an IUD, an intrauterine device that is progestin releasing. And there's really 3 different levels of progesterone you can offer. So there's even options within the IUD. And in most cases, the IUD will fit. Even if they have fibroids, it usually will fit. And we talk about, going with that option so that they don't have to be taking anything orally. A lot of your patients, as you know, are already on a lot of medications, and some of them like to have non-oral medication options. We also have progestin-only medications, some of which aren't labeled as contraception, but they really do a great job of thinning out the lining, like our medication norethindrone acetate works really well for heavy menstrual bleeding and for endometriosis. So some really good options to use progestin-only medications in patients. Now, some of these medications, it's really interesting because like agestin or norethindrone acetate, if you use it at high enough levels, there can be some conversion to estrogen. So you do have to pay attention to what you're giving and what are the risks of converting to estrogen. But in most patients, these are really low risk and a great option. And you could even consider having it on hand for patients just starting anticoagulation, having a progestin-only medication on hand or having them meet with us first right before they start anticoagulation.
Are there any non-hormonal approaches? You mentioned the treatment of fibroids if they exist, but anything else that could be considered in that regard?
Yeah, a lot of patients will respond to NSAIDs around the time of their menses. Now, those could interact with anticoagulants, so it's a little bit hard, but the NSAIDs do reduce bleeding about 20 to 40% if you take them right before the cycle starts. And that works by blocking those prostaglandins that I mentioned before. So NSAIDs are one option. And then again, the tranexamic acid, we use it for heavy menses only around the time of their period. So they can use it 3 times a day for up to 5 days a month, and it will reduce their bleeding by about 50%. A lot of patients will tell me that they actually have no bleeding while they're on it, but it might prolong their periods a little bit, but it works really well. Now, in the original studies, there's always worry about VTE, but in newer studies, it's really looking like that risk is very low. So again, I've worked with vascular and cardiovascular to go ahead and treat with tranexamic acid. The other option that we like a lot for patients who are done childbearing is endometrial ablation. So that's always an option. We basically use a device to treat the lining of the uterus, make it really thin down, kind of scar that endometrium. It doesn't get rid of all the endometrium. So if you have a patient who is really anovulatory and like really at risk for endometrial cancer, not the best option. But in patients who just have very heavy menstrual bleeding, are done having kids, and are bleeding, especially from anticoagulation, it's a great option. And it's a low risk procedure. I've taken patients with super low platelets to the OR and been able to do the ablation with almost no bleeding at all. So it's very effective, can happen very quickly in an OR setting, but while they're in the hospital, you can have set up that endometrial ablation pretty quickly.
Can those patients ever have children again? I know that some of my younger patients have asked about that option when they're struggling, and I've reached out to you actually with that question.
Yeah, no, we do not recommend ever getting pregnant because the scarring inside the uterus is pretty significant. And if they were to try to get pregnant, it could wind up in the cervix or in a fallopian tube. So an ectopic pregnancy, which is really high risk. So we definitely do not recommend that. And we would recommend one of the reversible options for bleeding if they're even considering down the road having a pregnancy. And in fact, with endometrial ablation, we usually recommend a pretty secure form of contraception like a tubal ligation or vasectomy. So we try to pair those while we're doing those procedures.
Okay, I see. Another question that's come up before when I've encountered patients with menorrhagia in my cardiovascular clinic is whether or not they should have a hysterectomy, or asking me if I can clear them from a cardiovascular perspective for a hysterectomy. What are your thoughts on that?
We try to preserve hysterectomy for patients who are a little bit older, and that's mainly because a lot of data has come out lately that we found taking out the uterus does impact the long-term risks of cardiovascular disease. So we do try to delay. We try to use some of the other options. In some patients, just bigger surgery, more complex surgery just isn't the best thing for them at that time. And so maybe we want to temporize until we can get there with other medications. But what we've been noticing in long-term studies is hysterectomy, even if you conserve both ovaries, does put patients at risk for coronary artery disease and congestive heart failure, as well as arrhythmias. So in one of our large studies out of the Rochester Epidemiology Project, we found that in women who had a hysterectomy, even with ovarian conservation under the age of 35, had a 2-fold increased risk of coronary artery disease and a 4.5-fold risk of congestive heart failure. So we really try to delay that. There's also data that shows about over 50% of patients will not have tried anything before going straight to hysterectomy. And so it's always good to see if we can just get some beneficial effect out of medications first before we would go there.
So even on that question, you mentioned that the age is a big part of that. So if they're younger than 35, what about some of my older patients who, clearly desire not to have any more children, or already perimenopausal and struggling with menorrhagia, maybe someone who's 55 years old? What are your thoughts on that? Is that risk still there? And how should I counsel, or what should my input be as a cardiologist?
Once we reach menopause, which is the average age of 51, we're already starting to accrue some of those medical conditions like cardiovascular disease. So it's probably less around age 45. I think hysterectomy is absolutely right for some patients who have failed other medical therapies, patients who definitely are done childbearing, and patients who have significant heavy menstrual bleeding. But of course, then we'd want to work with you all to make sure that they're optimized for surgery. One of the things I tell my patients, which they're not always aware of, is that when we do hysterectomy, and any gynecologic surgery, really, the best way to kind of prevent the bowel from getting in the way is to sort of tilt them on their head during the procedure a little bit. So they kind of get in a bed and they're tilted upward. And so some of the patients who maybe can't tolerate pressure on their lungs, or, we fill the belly with gas during that time, we really need that kind of thought process to go in when we're clearing them for surgery. So it's very helpful to talk with their cardiovascular specialist or their surgeon and say, is this the right time to do that surgery?
How about when you do the hysterectomy, you remove the uterus, do you remove the ovaries too, or are they always left behind?
A good discussion with the patient to have. We usually try to preserve the ovaries if we can, at least till age 50 or older. There's some data to show maybe we should save them till 60. That area is still a little gray, but before 50, we definitely tried to save the ovaries. There's some effects even after menopause that the ovaries have on the body. So they're still producing some hormones. And it's very helpful for things like to prevent against dementia and cardiovascular disease. So we try to keep them as long as possible. But if you have a family history of ovarian cancer or already have a history of breast cancer, or are concerned about a genetic mutation that might put you at risk for ovarian cancer, we certainly can remove them. And it's a conversation we have all the time. Now, it's really tricky in patients with cardiovascular disease because we often think like, if we're going to remove the ovaries, we can, just replace with hormones. But one, we're not great at hormone replacement. The ovaries do a better job than we can, but we're getting better at that hormone therapy. But then two, a lot of the hormone therapy includes estrogen. So it's always important to have that conversation ahead of time. Like, what will we do with vasomotor symptoms? And this is not my area of expertise. I'm sure you're talking with someone about it, but there are lots of non-hormonal options for vasomotor symptoms too right now.
Yes, we will have another podcast in this series on that topic. This has been incredibly informative. We've talked about mutual patients, through the years many times, but I still learned so much from our discussion today. So thank you for entertaining these questions. Is there anything else you want to impart on, my colleagues and myself in terms of things that we should be aware of?
I have learned so much from working with all of you in cardiovascular medicine. And so just thank you. And thank you for bringing this to our attention where we're working on what we can do better for patients on anticoagulation, and we're raising awareness. So thanks.
Excellent. And I'd like to thank our listeners for tuning in to this podcast. Please, if you enjoyed this podcast, listen to other podcasts in our series focused on the intersection of cardiovascular disease and female reproductive health. And have a great day. Take care.
At Mayo Clinic, continuous learning fuels world-class care. I am Dr. Francisco Lopez Jimenez, Chair of the Division of Preventive Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Please check out the link cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who have already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.